Hello, everyone. Welcome to the presentation today on the introduction to the Centris Health MSSP ACO. My name is Cindy Campbell, and I am the Director of Clinical Quality with Kansas City Metropolitan Physicians Association, and we are one of the 4 entities that make up Centris Health. So Centris Health is Kansas City Metropolitan Physicians Association, Shawnee Mission Health System, University of Kansas Health System, and the North Kansas City Hospital Meritas Health System. So we are the independent representation for Centris Health, the independent practice representation. The objectives of today's presentation is to review what the fundamentals are of an MSSP ACO, and then we will outline the details that are specific to the Centris Health MSSP ACO. And then we will work to understand what the individual practice roles are in an MSSP ACO and how you can help to make it successful. Our agenda is the MSSP ACO overview, and then we will talk specific to Centris Health. We'll discuss the beneficiary attribution list, the quality measures that we will have to report on for the MSSP ACO. We'll talk about MIPS and MIPS reporting, and then how your individual practice can contribute to success. And then we will also talk about some of the FAQs or some of the questions that I have received from practices about the ACO and about their role in the ACO. So just as an overview to understand what a Medicare Shared Savings Program Accountable Care Organization is, it's not a place, it's not a thing, it is a contract. It's merely an agreement that we have gone into as a group of providers with CMS, with Medicare, to say that we will coordinate care. We will all work together to coordinate care. We will work to decrease the fragmented care that we often see in the fee-for-service system, and that we will together improve the quality for the Medicare patients, but at the same time, we will lower the overall cost of care. Okay, so then if we do this, we will in turn receive incentives from Medicare. So the shared savings portion, what does that mean? So Medicare will continue to pay all of the individual ACO providers that make up Centris Health MSSP ACO. They will continue to get paid for services as they always have under the Medicare fee-for-service payment system. However, at the end of the performance year, when all of the data comes in and we are able to look at what our quality performance scores are, and then we also look at what our cost is, and look at where our benchmark is for costs. And if we meet certain criteria, then we will be able to get a certain portion of the shared savings back into the organization. So that's where the shared savings portion comes from. And this is just a kind of a slide that Medicare uses that shows what the overall goal is. I think this is a really good slide because this is our goal. We are looking for achieving better care for individuals, better health for the entire population. And then at the same time, we're looking to lower the cost of care. And for this slide, this shows the different tracks that an organization or an ACO can choose to be in. So it goes from an MSSP track 1, which is an upside risk only, and then it shows the different criteria for what the different tracks are. And really the differentiating factor between the tracks are whether you are taking risk And if you are taking risk, then it increases the potential of shared savings that you get in return. So Centris Health specifically is in the MSSP Track 1, and I'll talk more about this in the next slide, but we are an upside risk only. And as you can kind of see in the bullet points in each of the boxes, it talks about what the criteria is to be in each one of those different tracks. And this is something that has to be chosen prior to going into an ACO. You have to decide what tracks you want to be in. This is just a slide that shows where the Medicare ACOs are throughout the country. This one is a little bit older because I believe we're still pretty close to about 600 ACOs throughout the country, with some of them being the majority are track 1 or no risk. However, we do see more starting to move into those downside risk models as well. So let's talk specific to Centris Health MSSP ACO. So we are comprised of 40 practices. We have about 35,000 attributed Medicare lives. We are a track 1, so we receive shared savings if we meet the requirements, but we don't have any, we are not liable for any shared risk or shared losses, so it's a no risk, it's upside only. We are a MIPS alternative payment or an APM model. And then we're in year 1. So year 1 is pay for reporting only. It is not pay for performance, which that will be when we move into year 2. Then we will start looking at pay for performance. However, this year we are 2018, we're year 1, so pay for reporting. So beneficiary attribution. So earlier in the year, you may or may not have received a list via a secured email that showed your beneficiaries that were attributed to your practice. So patients were attributed to your practice based on data from the patient's use of services in the previous year. So it was a retrospective look back. And it's based on the plurality of services. So if you are a specialty practice and you received a list of attributed patients, that means that they saw your specialist more than they saw their primary care physician. And so we're going to talk a little bit more about that through this presentation. Now you will note that this list will change about 20% throughout the performance year due to death and aging in, and then the plurality of services as they change. So we will, later in the year, we will receive another attribution list. You'll note that it will look different because of those factors. So we have Medicare patients that have died. We have those that have aged in through the year, and then we have those that have changed where they have received the plurality of services. So they'll fall off of your list. So you might ask, why do we need to know what our list of attributed patients? What's the purpose of that? So the purpose is that it allows providers to reach out to those assigned patients proactively to help coordinate care, develop tailored care management programs for those that might have chronic illnesses that we know that are maybe utilizing the ED or excessively, or that have multiple admissions. So it helps us to start designing what we need to do, what kind of services we need to provide for those patients to keep them out of the emergency room, keep them out of the hospital. It also helps us to know where we can start reaching out and making sure we're getting preventive care and routine exams. And it also helps us to overall improve that quality and reduce the cost of care. So for those specialists those specialty practices that have been receiving or you have received a list of attributed patients, then one of the things that we are encouraging you to do is to start encouraging those patients to get to their primary care physicians so that they can start moving off of your list of attributed patients and move on to the primary care physician list. And that's going to be really important when we are talking about the quality measures and how to meet those quality measures. So I'm going to talk about that on this slide here. So we have 31 measures, these that fall into 4 domains. The 4 domains are patient and caregiver experience, care coordination, patient safety, preventive health, and at-risk populations. So these measures will be polled via a CAP, so that's patient experience, the CAP survey. It will also be done via claims measures. And then we also have what we call wireless interface or EHR. So you'll also note that many of these are primary care measures. And so this is one of the reasons that we want to encourage our specialists to start to get their attributed patients in to see their primary care so that we can start meeting these measures already. We're going to talk a minute about the MIPS APM scoring. So as a part of the Medicare Shared Savings Program Accountable Care Organization, you will be under a preferential scoring called MIPS APM scoring standard. So there's going to be a lot of benefits for you as a part of an ACO. So if you look at this far left-hand side, you'll see that there's 4 standards or 4 categories on that far left-hand side. So 30% is cost, and then we have a quality cost and improvement activities and an accountable, I'm sorry, advancing care information. So as a part of the MSSP ACO, you will actually move into having to only report on 3 categories versus 4. So that cost category goes away and the quality part gets increased, which is a good thing because the cost is going to be one of the hardest things to achieve. You will also receive full credit for improvement activities. And the only thing that you will have to report on is advancing care information, or ACI. So I want to kind of go back and talk just a minute about the quality measures portion of this, or the quality measure category of MIPS, and why it's a good thing that it moves from 30% to 50%. So what we do know about our quality measures is that from past performance, we have done really well. So we are already going into this really strong because we have some past performance from being in, ACOs are a majority of our primary care physicians have already been in ACOs. Primary care has been doing these measures for some time. They have already got well-developed routines, workflows, and in order to capture those measures. So we know from past performance that we are going into the quality piece very strong. So that's a good thing for all of you. So the other part about being in a MIPS APM scoring standard is it's going to reduce the reporting burden upon your practice. because you will not have to report on MIPS. You will only have to report on the ACI. So it's reduced your reporting burden significantly. So just to kind of go over those points again, your MSSP ACO practice will not have to report on MIPS. You will get 100% credit for improvement activities. And we are currently in year 1, so that's pay for reporting. It is not pay for performance until 2019 reporting year. And then the other thing is that all you will have to report on is the advancing care information on your own. And that's going to be things like, are you using a certified EHR? Are you doing a security risk analysis? Those types of things. So it's pretty much a yes or no. And just, I think it's important to note, advancing care information will also be changing. It's going to be called promoting interoperability versus ACI. So how can your individual practice contribute to success of the ACO? So if you're a primary care practice, really focusing in on those quality measures, making sure that you have good workflows established, that you are capturing those quality measures on your entire patient population. Do not just try to focus in on Medicare, but really look at workflows for your entire patient population. And from what we know with working with our primary care practices, is this is what they're doing. And what they're really doing is just trying to to develop enhanced processes and doing quality checks, making sure that they are capturing all of those parts and pieces. And looking at annual wellness visits, are we getting all of our Medicare patients in for those annual wellness visits for preventive health? Are we doing transitions of care and discharge med rec around those patients that are discharged from the hospitals and those transitions of care? Looking at population health as across your patient population, and encouraging and making sure that we have workflows developed to capture gaps in care and around different things, preventive care. Are we getting flu shots? Are we getting, do our patients getting their pneumonia shots? And looking at our diabetic patient population, are we ensuring that we're capturing hemoglobin A1Cs on our entire patient population? So, and also looking at chronic conditions, looking at, ensuring that we have good workflows for each of those chronic conditions, that we're not just, looking at those that might be sicker than the rest, but what we're really doing is looking at making sure that we have practices established for those conditions and for anyone with those conditions. So looking at things like our diabetics, coronary artery disease, making sure that we're getting those lab tests done on a routine basis. BMI, are we monitoring those patients? Are we sending them to a dietitian? Are we making sure that we're monitoring them across the continuum of time? So specialists, what can you be doing in order to help capture and the quality measures for these patients? Well, it's going to be one of those things where, do you really want to start doing primary care practices or measures and capturing those things? Or do you want to start really encouraging them to get to see their primary care physician? So that's really what we are encouraging the specialists to do, is to encourage your patients to get to their primary care physician, because your primary care physician is already capturing these measures. They're already looking at those. And we don't want you to have to do extra work. So the biggest impact that a specialist will have is on the cost of care versus the quality measures. So making sure that you have good care coordination processes happening with your primary care. Are you decreasing your duplication of tests and labs? Are you making sure that if you need a lab value or a test, has it already been done with your primary care or that patient's primary care practice? But also helping your patients um, to decrease or prevent emergency department use. Are we encouraging those patients to, get into their primary care physician? Are we, making access a little bit different so that we're not just saying go to the emergency room? And we also want to look at, the admissions too. What are we doing to make sure patients don't get admitted to the hospital? Are we being proactive so that we can capture that prior to those patients getting to that state where they have to be admitted? So frequently asked questions. So these are just a list of some of the questions that I have received across the since we've started the performance year of 2018. And so the first one here, what will my practice need to do for MIPS reporting? Well, basically, we really kind of covered that, and basically there's nothing that you really need to do for MIPS except for that ACI portion, and everything else is going to be reported at the ACO level. How do we know poor quality scores from other members won't affect our practice scores? So just to, if you recall, we are in the year one, so that is pay for reporting only. So there's no downside risk to the scores. And then we are also going into this with a high degree of confidence based off of past historical performance of especially our primary care practices and those that were previously in an accountable care organization. How are beneficiary attribution lists decided? So that's basically a retrospective look back on plurality of services. And once those are reconfigured, then we will be able to see, once again, it's going to look back at what the plurality of services are through the year. How will my specialty practice be able to meet MSSP measures that are primarily a primary care measure? So unless you want to start doing capturing those measures within the specialty practice, what we encourage you to do is to have your patients to go to their primary care physician for an annual wellness visit, and to, if they don't have one, to partner with a primary care physician that is part of the ACO, and that way it will fall off of your attributed list, and it will move to that patient will move to the primary care physician where they are already doing those measures. They have workflows and processes in place to capture those measures. Will there be technology used that tracks our data progress? And yes, there is. We being Centris Health, is in agreement with Cerner to utilize their their software platform of Healthy Intent, Population Health, where we will not only be looking at claims data, but we will be looking at, we'll be able to pull the measures and data from the EHRs and get a well-rounded picture of where we are with our quality measures. So that ends our presentation today on the introduction to the MSSP ACO. If you have any questions, please don't hesitate to contact me at cindy.campbell@physicians kcmetrophysicians.com. Thank you.